Okay, while we wait for a few minutes for people to come, are there any questions that you'd like to ask me before we start today? Just put it on the chat or just switch your microphone on.
Sir, Morbid's type 2 එකයි second degree heart block එකේ type 3 එකේ ECG වල මේ ඒකේ සර් අඳුර ගන්න පුළුවන් වෙනස්කමක් තියෙනවද?
අර type 3 එකේ හැම වෙලේම there'll be a fixed ratio. ඒ කියන්නේ P wave 3කට QRS complex එකක් ඒ වගේ. අර කිසිම ratio එකක් නැහැ. ඔව්.
ඒතකොට සර් ඒකේ QRS දෙක තුනක් ගිහිල්ලා එකක් නැතිව එහෙම එන්නේ නැහැ.
එහෙම එන්නේ නැහැ. හැම වෙලේම fixed ratio එකක් තියෙන්නේ.
ඒතකොට Morbid's type 2 Morbid's type 2 එකේ predict කරන්න බැරි තැනකින්
එකපාරට මිස් වෙනවා. ඔව්. හරි. ඒක හරි. Harry, shall we start then? Okay. Right. Okay, so just to recapitulate what we did yesterday. Oh, තා ප්‍රශ්නයක් තියෙනවා. මොකද්ද මහේෂ් අහන්නේ? So, Mahesh, treatment of these sort of conduction problems, I will teach later when you do your professorial appointments. We talk about emergency management. Bradycardia and conduction block management is slightly more complicated to teach now. Whatever it is, the principle is if you have a patient with a conduction problem, if they are unstable or hypotensive, then you have to put a pacemaker in. There is no doubt about that. So if they are unstable or hypotensive, pacemaker ka daan doni. That is clear, regardless of the type of the block. Even if that is not the case, there are certain high-risk types of blocks. Hari? එතකොට ඒක මම පස්සේ කියලා දෙනවා what are the high risk things and එහෙම කියලා අපි පස්සේ බලමු. Okay, so just to recap what we talked about yesterday, when you look at any ECG, ඕනම ECG එකක් දිහා බලනකොට there are 5 important things that you need to look at. The first thing is, obviously, you need to calculate the rate and assess whether it is regular or irregular. Very important. Ari? The next thing you do is calculate the cardiac axis. And we talked about this. You can use this orientation. I told you have to remember this. Lead placement. A lead is like a window that looks at the electrical activity of the heart. So looking at this, you will be able to work out the direction of the cardiac impulse. Okay, and that is the axis, right? So we talked about normal axis, left axis, right axis, and so on. Then we talked in detail about rhythm analysis, and I told you that there are various types of rhythms. There is a sinus rhythm, there could be atrial rhythms, there could be nodal rhythms, or there could be ventricular rhythms. A rhythm essentially is a description of where the prominent or driving cardiac impulse starts. So if that is in the sinus node, it is a sinus rhythm, for example. All right. Now, then we went through various ECG patterns. I told you that if it's sinus rhythm, you will get a normal P, normal QRS complex. If it is an atrial rhythm, you will get abnormal P waves, and there are various types of abnormal P waves. Atrial fibrillation, flutter, unifocal or multifocal atrial tachycardia, right? And then those are the atrial rhythms. Absent P QRS only would be a nodal rhythm. If make absent Q, I told you that there can be a retrograde P from the AV node back upwards, but that is very difficult to spot, right? So essentially for a medical student, a nodal rhythm is a P, it is a QRS without a P, right? It is a QRS without a P. Then we went into when the QRS complex is abnormal, it is a ventricular rhythm. Most often that is the case. So ventricular tachycardia, unimorphic or sort of polymorphic ventricular tachycardia, ventricular fibrillation. ඒ වගේ අපි ඊයේ බැලුවා. Then we went into conduction analysis. I told you that there are two main places that you can get conduction problems. AV node, so we have type 1, type 2, right? And there are three types of type 2 block. Mobitz type 1 is prolongation of the PR interval and missing of the beat. Here there is no such relationship in type 2, and I also told you there is something called type 3, where it's a fixed sort of block. 3 to 1 or 2 to 1 or 4 to 1 or whatever is the case. In complete heart block, there is complete AV dissociation, but the atria is functioning on its own, the ventricle is functioning on its own, they do not communicate. And then we talked about bundle branch blocks and William Marrow, left bundle branch block, right bundle branch block. Okay. Now, if there are no questions, right, and again, I will teach these again when we talk about examples when you come to a professorial appointment, but this is just to make a ECG ගැන කතා කරන අන්තිම අවස්ථාව නෙවෙයි. So the last time we are going to talk about ECGs, we are going to keep on talking about them. But I think because you have not had any formal lectures on ECGs, I think it's important for us to establish some sort of baseline where you have an idea of what it is. Hari? Okay. Okay, fine. Now, for today's discussion, we will talk about individual waveforms and segments. So let's start off with the P wave, the P wave. Now, I'll first put my sort of marker or whatever on, then I can show you these. Right. Hi. Now here, just give me a second. Okay. So the first abnormality of the P wave I would like to show you is this. Okay. This is a bifid P wave, like a M. Very characteristic shape, bifid P wave. A bifid P wave like this occurs very commonly or most often when there is hypertrophy of the left atrium. So left atrial hypertrophy. And this often occurs in mitral stenosis. So this is also called P mitrale. P mitrale. So a bifid P wave. There are other conditions that cause a bifid P wave. Most often it is due to hypertrophy of the left atrium, and that is often associated with mitral stenosis. That's called P mitrale. It's like P mitrale. We call this P mitrale. Now, this is another abnormal type of P wave. As you can see, it is very tall, right? So, very large looking P wave, right? Very large, big looking P wave. And that occurs when there is right atrial hypertrophy. There is hypertrophy of the right atrium. And this is called P pulmonale. P pulmonale. So, there's hypertrophy of the right atrium. You get a very tall P wave, a peaked P wave, and that is called P pulmonale. P pulmonale. Right. So that is about the P wave. Right. Then we move on to the ST segment. And obviously, as an undergraduate and as a practicing doctor, the most important problem in the ST segment is ST elevation. And obviously, at this stage in your final year, you should be able to spot ST elevations like this. Right? ST elevations, you can see these. Now, obviously, spotting ST elevations is important, but then you have to know the causes of ST elevations. The most important cause of ST elevation is, as you know, ST elevation, myocardial infarction. But there are other causes of ST elevations also, and I would say pericarditis is the other one that you need to know. Pericarditis. So ST elevation, two important causes. ST elevation in mind, obviously, but the other one is pericarditis. Now, write down here that in pericarditis versus ST elevation MI, the morphology or the shape of the ST segment can be different, essentially. In ST elevation, it is a horizontal elevation like this. So that is the ST elevation. It is a horizontal, like that. But in pericarditis, it is more like this. No, so this is called a saddle-shaped ST elevation. It's called a saddle-shaped ST. So the morphology of the ST elevation is different when it comes to ST elevation MI to pericarditis. So ST elevation MI is a straight up horizontal elevation, whereas a pericarditis is more of a saddle-shaped ST elevation. And the other difference is in pericarditis, because the pericardium is everywhere, you see ST elevations in almost all the leads. It's more diffuse everywhere. Those are the two main differences. Now the next important thing, we're talking about location, is that by looking at the ST elevation, you should be able to tell where the infarction is. Where the infarction is. Now for this, you need to have a knowledge of lead placement. If you know your lead placement, you can work out where the problem is. Now look at this example. You can see ST elevations in V1, V2, V3, V4. So where is the MI? Remember we talked about this yesterday. V1 to V6, look at the anterior surface of the heart, like that. So when you see ST elevation from V1, V2, V3, V4, you know that the infarction is there. So it is an anterior infarction, like that. It is an anterior infarction. So that is your knowledge of lead placement. And you know where the area of the infarct is. So it is anterior ST elevation, MI, anterior, in the front. Because V1 to V6 we know are windows that look at the electrical activity from the front of the heart. Right. Now then, where is the MI in this one? I'll give you a few minutes to have a look at this. So here you can see ST elevation there, and here. So lead 2, 3, and AVF. And from our knowledge of lead placement, we know that 2, 3, and AVF look from the inferior surface of the heart, from the bottom of the heart. We know that. So 2, 3, and AVF, they are windows that look from the bottom of the heart. So we know that this is an inferior stem. Inferior stem. Yes, Sanjay, it does look like saddle shaped, but in pericarditis, right? So it does look a little like, this is slightly more acute. Horizontal වෙන්නේ ටිකක් කල් ගියාම ලස්සන්ට horizontal වෙන්නේ a few hours afterwards, right? This is a more acute, say within a few minutes, say half an hour to 1 hour. ටිකක් කල් යනකොට තමයි it gets nicely flat like this. Fine. Again, inferior stem, you can see 2, 3 AVF. Right. Where is the MI here? So if you look carefully, there is ST elevation in lead 1, AVL, slightly in V2, V3, V1, all these leads. So think now, where is the stemming? Where is the stemming? So V1 to V6 all lines with extensive anterior, and remember I told you 1 and AVL are there. They look from the left side of the heart. Lead 1 and AVL specifically look from the left of the heart. So this is an extensive anterior and left lateral MI. So it goes to the side, left lateral, because 1 and AVL also you are seeing ST elevations, and that is right. 1 and AVL also you are seeing ST elevations, and therefore You know it's more anterolateral. It's more anterolateral. Anterolateral. Okay, fine. Right. This is not very important, but fine. Right. This is also okay. What is the problem here? Where are the ST elevations? So they are two, maybe a little bit here, but not, yeah, that's not really sure. Yeah. AVF, yes, definitely. So this is again slow, sort of an inferior stem, right? There's something else going on here. I will teach this later, right? Just observe this, and we can talk about this later when you are better at ECGs. Prof කරනකොට. But essentially, you need to identify anterior STEMIs, inferior STEMIs, anterolateral STEMIs. Those are the things that you need to know. Hi. Okay, fine. Now, the ST segment can also be depressed. So you can see here ST depression. So ST elevation, ST depression. Remember that ST depression due to ischemia, right? You know that ST depression can occur due to ischemia. That is usually horizontal or downsloping. So the ST depression when occurs due to ischemia is either horizontal or downsloping. Upsloping ST depression, where the ST depression is like that, is not a feature of ischemia. It's not a feature of ischemia. So somebody asks you, ST depressions, horizontal and downsloping, are suggestive of ischemia. Right. Okay. Now the last part. Okay, last part. So we have talked about the P wave, we have talked about the ST segment. Now we are talking about the T wave. A T wave, as you know, can be inverted. Fine, you already know that. I'm not going to show you a picture of that. But this T wave, you can see another abnormality, which is quite obvious. This is a tall tented T wave. So in the T wave, what you're looking for is essentially a tall tented T wave of hyperkalemia. Hyperkalemia. Right. Now, in this ECG, you can see another sort of wave after the T wave. So that what is that? That is a U wave. Right? U wave, which occurs in patients with low potassium levels, hypokalemia. Hypokalemia. So in the T wave, you are looking for T inversions, you are looking for tall tented T waves of hyperkalemia. And then if you get another positive wave after the T wave, that is hypokalemia, and it's called a U wave. U wave. So that is essentially your ECG basics level. Okay, so just to remind you, what are the ECG basics? Number one, rate, axis, rhythm, conduction. And today we talked about all of that yesterday. Today we talked about individual waveforms, which is very easy. P wave, right? P wave, P mitrale, P pulmonale, ST elevations, ST depressions, right? And identifying where the MI is exactly, then T waves and U waves. That's what you look for. Right. What is going on here? Right. You can type the answer on the chat if you like. Yes, Kavit. So, tall tented T waves only in some leads. It is best seen in the precordial leads. May samane lead place karana vidya anuව තමයි, but it's usually best seen in the precordial leads. It should occur. Even here it's tall. What do you mean by tall? Is that it is half or above the R wave. So the height of the T wave is half or more than the R wave. That is what you define as a tall T wave. හරි. මේක බලන්න මොකක්ද තියෙන්නේ කියලා කියන්න බලන්න. Okay, so there's a good thought. Some people thought it was BT. Right? I think the reason is they thought that I told you yesterday that the QRS is broad. It is a ventricular rhythm. So could be ventricular. Neither. So yesterday I told you to look up for homework. What are the other causes of a broad QRS complex? So the other causes of a broad QRS could be hyperkalemia. Now look at this T wave. Yes, so massive there. So write down then, causes of a broad QRS complex is not only ventricular tachycardia or ventricular rhythms. It could also be due to hyperkalemia, right? Hyperkalemia. And you will see the tall tented T wave in association with that, as you can see very, very clearly in this ECG, hyperkalemia. The next cause of broad QRS is a tricyclic antidepressant overdose. Tricyclic antidepressant overdose can also cause a broad QRS complex. Right. Okay. The other thing that can cause a broad QRS complex is when there is a tachycardia, okay, a tachycardia which arises from above the ventricles, but there is a significant conduction block. So you have a tachycardia arising from above the ventricles, which should give rise to a normal or sort of narrowish QRS complex, but it doesn't because there is a significant conduction problem. The QRS gets broad. That's called a supraventricular tachycardia with aberrant conduction. The proper electrophysiological term for that is supraventricular tachycardia with aberrant conduction. That is another cause of a broad QRS complex. So broad QRS complex, ventricular rhythms, hyperkalemia, tricyclic antidepressant overdose, and supraventricular. So what that means is the electrical activity abnormal tachycardia is arising from above the ventricles. It is coming down, but it's being blocked along the way, and that causes broadening of the QRS complex. So those are the cause of a, and the last one is very difficult sometimes to differentiate from BT, right? And that is sometimes only by an expert that you can differentiate. Very difficult. I don't want you to worry about that. J point is, somebody's asked what the J point is. So J point is, you get a small notch just before the sort of ST segment. That's called a J point. I'll show you a picture later. Remind me. Okay. Hurry. Right. This is actually a more severe sort of form of hyperkalemia. Also, you can see the very broad QRS complex, and this is called a sine wave. This patient is sort of seconds from getting a cardiac arrest, essentially. Hi. Okay, this is not very important. This one. So, Shali, there is no height to say tall T wave. If the T wave is bigger than half of the R wave, that is considered to be tall. In millimeter ganak ne. Right? So, this is an interesting one, not very common. Anyone know what this one is? This is just for interest, if you like.
So Wolff-Parkinson.
Yeah, very good. So this is Wolff-Parkinson-White syndrome. Why do we say that? Because two reasons. One is you can see the PR interval is short. It's a few seconds, maybe 2 seconds. And you can see this. I'll enlarge this for you. So usually what happens is like this. So what happening here is you have this and so this is called the delta wave. This is Wolff-Parkinson-White syndrome, and it can be associated with various complicated arrhythmias, right? Again, that is postgraduate stuff. Sasanka is asking, is there a way to detect a posterior MI by looking at standard ECG? I will teach this later, Sasanka, because it's slightly more complicated, but essentially this is a posterior STEMI. But this is a posterior STEMI. The way you identify it is, if you have a prominent, you can see this method, a prominent R wave and ST depression in V1, V2, V3. V1, V2, V3. So what is the criteria for posterior STEMI? A dominant R wave. මේ සාමාන්‍ය වෙල එහෙම එකක් නැහැ. හරි ගොඩක් අයට නෙගටිව් මේ ගොඩක් ඒවා නෙගටිව්. So you will get a positive R wave or dominant R wave in V1, V2, V3 and ST depression in V1, V2, V3. Right? That is considered a posterior STEMI. Right? That's a posterior STEMI. It is very, very difficult to catch. ලංකාවේ විතර නෙවෙයි ඔක්ස්ෆර්ඩ් වලත් කාඩියල්ස් කෙනෙක් එකපාරක් එක මිස් කරලා එඩා මැරුණ ඇත්තටම. So essentially this is difficult to catch, but that is a posterior STEMI. මේක ඇත්තටම this ECG is a inferior posterior STEMI. මේ inferior වලත් තියෙනවා posterior වලත් තියෙනවා. Yes, see how many small squares. So it depends on whether it's the precordial or the limb lead. So that is 2 millimeters and 1 millimeter. Right. Okay, so that is ECG. Remember, this is not the so right ventricular infarction එක detect කරන්න you need a special lead and that is called V4R. ඒක නැතුව හරි අමාරුයි ඒක diagnose කරන්න. අපි සාමාන්‍යයෙන් කරනවා ඔක if there is a inferior posterior STEMI you do this V4R and that shows you the right ventricle directly. There are other leads also, you can do posterior leads. May V7, V8, V9 කියලා කරන්න පුළුවන් posterior leads. So you can ඒකතොර ලස්සනට you will see the ST elevations if it's a posterior STEMI. So those are additional leads that we sometimes ask the ECG technician to do. හැම වෙලේම කරන්නේ not standard leads. Okay, right. So how do you get a clue about a past MI? That is from Q waves, right? So if you have a past old MI, you will see Q waves, deep Q waves. But no, look Q waves the. Okay. Right. So that is all for ECG for the moment, right? There are some other things I want to teach you, but for the moment, that is it. Right. Any questions before we move on to the X-rays? Any questions before we go to the next part? Well, නිදි නෑ නේද?
Sir, Q wave එක appear වෙලා T invert වෙලා ඒ T inversion එක permanent වෙනවද MI වලද?
I can.
දැන් T ST segment elevate ලා ඊට පස්සේ Q T inversion එහෙම ඇවිල්ලා MI එකක දැන් Q wave නම් permanent නේ. ඒතකොට T inversion එකත් permanent වෙනවද?
ඒක හැම වෙලේම නෑ අචන සමහර වෙලාවට ඒක දිගටම තියෙන්න පුළුවන්. ඒක හැම වෙලේම වෙන්නේ නැහැ. But තියෙන පුළුවන්. ගොඩක් අය අපි දකිනවා එක දිගටම persist on the T wave inversion. Yeah. හරි. ප්‍රශ්න කිහිපයක් තියෙනවා අපි ඒකට උත්තර දෙලිමුකෝ. Right. So usually somebody's asked about QRS progression from V1 to V6. Usually Kasun has asked that question. How does so usually Kasun V1 to V2 V3 it's usually negative deflection. V5 V6 V4 it's usually positive. So it transitions from a negative to a positive thing. That is called the QRS progression. Kavindya asks, how you differentiate hyperacute MI tall T with hyperkalemia? It is very difficult, and you are right. It is from clinical presentation. Hari amarui. I ගොඩක් වෙලාවට Kavindya අපි hyperacute MI කියන එක detect කරන්න බෑ because the patient generally gets about half an hour late unless somebody gets a STEMI in hospital and you record ECG immediately or something. It is very difficult to detect it. Hari ensa, but it's very difficult to differentiate. ECG changes MI අපි පස්සේ theory කරනකොට කරමු. There are other causes of tall T waves, Maya, but the most important one is hyperkalemia. Somebody asks, what is the significance of the cardiac axis? There's nothing very much significant about it. It is something that you have to comment on always. Like a look axis එක වමට දකුණට තිබ්බගේ ලොකුවට මහ ලොකු බලපෑමක් නැහැ clinically. But it's something that you have to report when you are reporting a ECG. Bellin syndrome are specific things. We will talk about those later, right? They are sort of ischemic heart disease related ECGs. Which ones that teen? So remember, Harshana, that's an important question. Teen versions, mehemai. In females, you might see teen versions V1 to V3. In a normal person, but normal if the patient comes with chest pain and you see T inversions, even if it's a female V1 to V3, you'll always repeat it to see if there is any change. Samahalata in females, normal person people also you will see V1 to V3 T inversion. Okay, පොතක් තියෙනවා ECG in practice කියලා අර ඔයගොල්ලෝ ECG මේ DC එකේ තව පොත් දෙකක් තියෙනවා ECG in practice and something else. ඒ ECG in practice එකේ තියෙනවා මුල chapter එකේ normal variants ටික වගේක්. ඒව ටික නිකන් ඕල් interested නම් බලන්න. ඒතකොට females ලගේ මේක normal variant එකක් කොහොම කීකේ තියෙන්න පුළුවන්. කවුරු ප්‍රශ්නයක් අහන්න ගත්තා නේද?
සර් dynamic and non-dynamic changes කියලා ගන්නේ මොකක් මත depend වෙලාද?
ඒක මෙහෙමයි පියු මේ dynamic කියන එකට හරි definition එක ගන්න නැහැ. chest pain තියෙන මිනිස්සෙක ECG එක වෙනස් වෙලා නම් say for example first ECG you didn't see anything second ECG you see T inversions or something or මුලින් තිබ්බ වෙනස නැති වෙලා නම් හරි we refer to this as dynamic changes. හැබැයි ඔක හරියට අර පොතක ලියවිලා නැහැ what dynamic කියන එක definition එකක් නැහැ. Essentially it's a changing ECG in a patient with chest pain.
Thank you sir.
Right. Achala is asking how do we need to comment on reciprocal changes? Not always. I will show some ECGs when you're doing more practical examples. Basic principles වලට අදාළ නැහැ. Reciprocal can think like STEMI වලදී අපිට කියන්න පුළුවන් reciprocal changes ගැන comment කරන්න පුළුවන් අත්‍යවශ්‍ය නැහැ ඉතින් ඒක ලොකු බලපෑමක් නැහැ ඒක කරන්නේ. Okay, right. So let's move on then to chest X-rays. Now, sorry, in radiology in general, but I think chest X-rays are the most important thing that you as a medical student will have. All right, right. Okay. All right. Now this is a normal chest X-ray. Now, there are a few important principles when you look at chest X-rays. Again, like in an ECG, there is an order in which you comment on it. The order. Right. The first thing to do is look at the airways. Okay, airway. Airways leading into the lung fields. අපි airway එක දිගේ trace කරගෙන එනවා leading into the lung fields. Then look at the blood vessels. මේ බලන්න මේ මෙතන near the hilum you see blood vessels. Blood vessels. Okay, so airways and lung shadows. blood vessels, and then the cardiac shadow. See, so okay, ABC කියලා මතක තියාගන්න පුළුවන් වුණා. Airway and lung මොකක් හරි, right? Blood vessels, and then blood vessels වුණා තව එකක් දාගන්න bone. ඒක ඒ වෙලාවෙන් බලන්න ඕනේ නැහැ, but you can look at the bones also, right? And then C is cardiac shadow, C, and then D is diaphragm එක ගැන සහ උඩ යට ඔක්කොම තියෙන ඒවා ටික කියන්න ඕනේ. So if you remember A, B, C, D, that is fine. Airway and lung fields, A. B is blood vessels and bone. Bone will be mainly clavicles and ribs, right? Then C is cardiac contour, cardiac shadow, and D is diaphragm. That is the way you usually approach looking at a chest X-ray. So now let's start with abnormalities of the lung fields and air passages. Okay, air passages වල මහ ලොකු abnormality එකක් ඉන්නේ. Lung fields වල තමයි abnormality එක ඉන්නේ. Right. Now, if you classify the radiological abnormalities on a chest X-ray, very easily you can classify it saying there are white lesions, සුදු පාට දේවල් තියෙනවා, and there are black lesions. So there are white lesions and black lesions. So we'll first focus our attention on white lesions. Sudu part of the white lesions. What are the white lesions that you see? Right. Now in this you can see a white lesion. Obviously, you will see a white color thing. And there are certain features of this white color thing. You can see here. Method. Okay. First of all, it is a homogeneous opacity. Homogeneous can ekama pattern. It's the same white, same color. Homogeneous opacity. Right? Homogeneous, and you cannot see the diaphragm separately. So it is homogeneous opacity continuing with the diaphragmatic shadow. The diaphragmatic shadow you cannot see. So it is this homogeneous opacity is continuing downwards. And if you look at the upper border, you will see a meniscal upper border, right? Meniscus. Drava mavake kiyane meniscus. Yes, that is a meniscal upper border. So homogeneous opacity. These are white. So white lesions, black lesions. This is your classification. White lesions. This is a homogeneous opacity on the left hemithorax. You cannot see the diaphragmatic border differentiate. You cannot separate it out, right? And you will see a meniscal upper border. So what is this then? This is a pleural effusion. Everybody knows it is a pleural effusion. But you have to describe. Sometimes in the OSCE we ask you to describe the chest X-ray. So the pleural effusion you have to write the description. So this is a homogeneous opacity in the left hemithorax. The diaphragmatic border cannot be seen separately, and there is a meniscal upper border. So therefore, this is a pleural effusion. So that is that. Now let's look at the next one. Now here again you can see a white color thing there. Homogeneous opacification, right? Like you saw earlier. The diaphragmatic border cannot be seen separately. It's essentially the same as the previous slide. The main difference is the upper border is flat. So previously you saw a meniscal upper border. Here you see the upper border is flat. So this is what we call a hemopneumothorax. Hemopneumothorax or a hydropneumothorax. So there is some fluid and there is also air in the pleural cavity. This is very common after trauma actually, right? And what's happening is that air column is pressing on the meniscus and flattening it out. So this is a hydropneumothorax. Hydro means water. You don't know what it is, what is inside it. In trauma, you commonly see hemopneumothorax, where there is blood in the pleural cavity. So what is happening is there is gas and blood. So the meniscal upper border that you saw in the previous slide is now flattened out. And this, you can see this air also here, that is gas. There is a pneumo component there. Okay, again, if you have any questions, please immediately put them on the group. Okay, fine. Right. Now let's look at these two X-rays. Again, you see a white color lesion here. So white. But unlike the pleural effusion you saw, this is more heterogeneous. You can see that it is heterogeneous. And also, if you look carefully, you can see sort of air passages outlined in around the white. So the air passages are highlighted on a background of white. This is called an air bronchogram. So it is a heterogeneous opacity. You might see an air bronchogram. What it means is the gas filled the air passages are highlighted against a white background. So we call it air bronchogram. Air bronchogram. So the heterogeneous opacity, air bronchogram, and this is confined to a lung lobe. This is the upper lobe. Upper lobe. So this is a right upper lobe consolidation. So the definition of a consolidation on a chest X-ray would be heterogeneous opacity with air bronchograms. That is a consolidation. Because it's confined to a lobe, in this case, it is a consolidation of the upper lobe or a lobar consolidation. Now compare this lamai with this picture. It is almost the same. The only thing is, can you see this? The shape is a bit different. So what has happened? This is the outline, outline of the horizontal fissure of the lung. What has happened in this one? The horizontal fissure, imagine, the horizontal fissure has been pulled up like this. Here. So what has happened? This is a collapse consolidation. Collapse because the upper part, the lung, right upper lobe has collapsed also. The upper, this transverse fissure, horizontal fissure is being pulled upwards. And so this, the second X-ray is a collapse consolidation. It is a collapse consolidation. So here you learn the definition of a consolidation is a heterogeneous opacity, air bronchogram. That is the story. But you can have a superadded collapse if the fissure is displaced. Right. Okay. Now what is this? What is this? What you see essentially here is that there is a sort of almost complete whiteout of the hemithorax. There is almost a complete whiteout of the left hemithorax. Again, white lesion almost completely sudui. Now there are some differential diagnoses of this appearance. What are they? White out of one side. White out of one side. What is the differential diagnosis? Number one, massive pleural effusion. Massive pleural effusion. Number two, left or whatever, lung collapse. Lung collapse. Lung collapse. Lung collapse. Tuna, pneumonectomy. Pneumonectomy. So, could be a massive pleural effusion. It could be a collapse of the left lung in this case, or it could be a pneumonectomy. Pneumonectomy, lung ke galola. Various reasons for doing that. Obviously, things like cancer, you sometimes remove the lung complete. Eka lung ekin jiwath wenna bari kamak naha. Hari. So what is this? What is this? Meka hari amaru yogolonta kiyanna, but if you just stand back from your screen, you will see this. Me balanna. Ame da andinawa puding. Hemming. What is that? And also you cannot see the cardiac border on this side. But the cardiac border ka penne. So of these three, what do you think this is? So what has happened here is the lung has collapsed, right? And what is happening to the diaphragm, because of the lung collapse, the diaphragm is going pushed upward. Lung collapse, diaphragm collapse, right? So this is a left lung collapse. So differential diagnosis of a total whiteout on a hemithorax would be pleural effusion, collapse of the lung, or pneumonectomy. In a collapse of the lung, there are two important features. You won't see the heart border, that will be obscured, and then you will get a sort of diaphragm being pulled up because of the volume loss. The diaphragm is now pulled up. And that is what you would see. That is what you would see. Yes. So there are a few questions. Lung collapse is not a black lesion because lung collapse, it becomes a solid structure. There is no air inside. So Pacer is asking a very important question. Yes, Pacer, that's right. Shouldn't the trachea be deviated to the same side in lung collapse? Yes, it should. It is not very clear here. I agree. But ideally, the third thing you would see in a lung collapse would be the trachea being shifted that way. I think there's some mass or something also, but that is something which you don't need to worry about. But so there are three things when a lung collapses. The diaphragm is pulled up, the trachea is pulled that way, trachea, and this white out on one side with the obscured or indistinct cardiac border. Indistinct cardiac border, obscure cardiac border. Okay, fine. Right. What do you see? This, what is this? Again, this is the same sort of thing on the other side. So differential diagnoses of a whiteout then are, number one, pleural effusion, massive pleural effusion, collapse of the lung, and then finally a pneumonectomy. Now here, basically, you can see that the trachea is very nicely deviated to this side. Okay, so that is evidence that diaphragm එක එච්චරම හොඳට පේන්නේ නැහැ මෙතන අර තරම්ම, but okay. So what is this? This could be a collapse, right? It could be a collapse. Remember that a collapse looks very, very similar to a pneumonectomy. Right? Collapse is antima deka api kiyapu. Collapse and pneumonia, their X-rays look very, very similar. They are identical almost, except for one important difference. Can you see in this X-ray when a methane, that is a surgical clip on the rib. So that you see in a pneumonectomy. So this is actually new. So pneumonectomy and collapse are very similar. They are very difficult to differentiate. But here, because we see a surgical clip, we say this is probably a pneumonectomy. Sharat is asking, why does the trachea get pulled to the same side? Why, Sharat, when the lung collapses, it pulls it. Pulls the trachea. The volume loss, mediastinum is a very sort of elastic structure. When there is volume loss on one side, the mediastinum is pulled to that side. That is why. Okay, fine. And then you see in this one, you see the surgical clip. So it is probably a pneumonectomy more than a collapse. But sometimes it is very difficult to differentiate. So I have told you three differential diagnoses then of a whiteout on one side of the lung. Again, this is another example. Whiteout of the lung, diaphragm එක උඩ ගිහිල්ලා ටිකක්, heart board එක එච්චර පේන්නේ නැහැ. This is again a collapse. If you look carefully, මෙතන වෙලා තියෙන්නේ මොකද්ද කියලා. So this collapse is due to මේ ET tube එකක් තියෙනවා පේනවද මේ ඇතුලේ. ඔය ET tube එක අස්සට ගිහිල්ලා වැඩි. ET tube එක අස්සට ගියා වැඩි වුණාම, if it goes on to this side, so that is you are selectively intubating the right lung, so that other lung collapses, right? So මේක මේ ET tube එක ඇතුළට දාලා වැඩි. That is the reason why this lung has collapsed. But look at the features of lung collapse again. Essentially, you are seeing, right, whiteout, diaphragm, බැලුවොත් diaphragm එක පොඩ්ඩක් ඉස්සිලා වගේ පේනවා hard border indistinct and trachea එක එච්චර පැහැදිලිව පේන්නේ නැහැ මේ පැත්තට ඇදිලා ඇති. හරි okay. Right.
Excuse me, sir.
Yes, please.
Sir,
Yeah.
after
Okay, sorry.
after pneumonectomy, sir, isn't rib cage filled with air?
No. No. Again, rib cage එක collapse වෙනවා. That is, for example, you don't lung එක තනිකරම අයින් කරන්නේ පොඩි tissue කැලක් අයින් කරලා තමයි ගැට ගහනවා. එතකොට අර මේ diaphragm එක උඩ යනවා and the sort of the soft tissue sort of collapses. So it's not air completely. Okay.
Thank you, sir.
Right. Hari. This again is I have shown, sorry, මේක මුලදී දාන්න තිබුණේ. So this is again a consolidation. පේනවද නේද මේක? So heterogeneous opacity upper lobe with air bronchogram. Okay. Right. Now just to show you some other important stuff, here is another consolidation. So you can see the consolidation here. නේද? මෙතනත් අපිට consolidation එකක් පේනවා. So it is again a heterogeneous opacity. You can see that very nicely. මෙතන ලියා ගන්න, this is a special type of consolidation which is wedge shaped consolidation. මේ බලන්න මේ. Wedge shaped. This occurs in pulmonary embolism. Pulmonary embolism because of lung infarction. So infarction of the lung. Okay, is an infarction of the lung. Hari. දැන් අපි ඒ ටිකයි පොඩ්ඩක් බලාගෙන ඉමු. So chest X-ray, airway lung shadows, bones and blood vessels, heart shadow and diaphragm. Those are the things that you look at. White lesions, black lesions. White lesions can be upper border, sort of this sort of pleural effusion, hydropneumothorax, a heterogeneous opacity, bare bronchograms, consolidation, white out on one side, right? 3 differential diagnoses, collapse and pneumonectomy look the same sometimes, right? And then various types of consolidations also have shown. Right, now let's look at this. Right. මේ ECG එක දිහා, sorry, X-ray එක දිහා බැලුවම ඔයගොල්ලන්ට තේරෙනවා patchy sort of whitish stuff everywhere නේද? Patchy whitish stuff everywhere. There are 3 differential diagnoses, 3 or 4 differential diagnoses of this appearance. දැන් අපි ඒ ටික බලමු. X-ray වල ගොඩක් වෙලාවට differential diagnosis දෙන්නත් පුළුවන් තමයි. මේ වගේ මේ හැමතැනම සුදු ටිකක් patches වගේ තියෙන X-ray වල දැකලා තියෙන්නේ. So what are these? Patches. Obviously these sort of patches are very familiar now. Hari, very familiar now because of what? COVID. So any sort of diffuse sort of pneumonia, right? Bronchopneumonia, interstitial pneumonia can cause this sort of appearance. Right? Okay, appearance එකක් එන්න පුළුවන්. That's the first one. Second one, ARDS. Right? Adult or acute respiratory distress syndrome. Second one. Third one, pulmonary edema in heart failure, for example. Pulmonary edema. Number 4, interstitial lung disease or lung fibrosis, interstitial lung disease. So when you see a sort of sudupata patches everywhere, you have 4 differential diagnoses. Sometimes it's very difficult to differentiate these 4. Hari? Number 1 is severe pneumonia, patchy sort of pneumonia, right? COVID is a good example for that. Influenza is a good example for that. Right? And some bacterial stuff, like say for example, mycoplasma. Number 2, ARDS. Number 3, pulmonary edema. Number 4, interstitial lung disease. Now, number 5, diffuse alveolar hemorrhage. Pulmonary hemorrhage කියන්නේ ඕක එනවා අපිට මේ අපේ ඔගොල්ලෝගේ level එකට යනවනේ leptospirosis. There are lots of other causes of pulmonary hemorrhage, good pasture syndrome මේක නම් කවදාකවත් දකින්න හම්බෙන දේවල් නෙවෙයි. But we know leptospirosis. So ඒ වගේ ඒවා එන්න පුළුවන්. So there are 5 differential diagnoses. These sort of patchy සුදු everywhere X-ray. Right, patchy sudu everywhere X-ray. These are the differential diagnoses. Right. So again, similar sort of things. The only clue sometimes to differentiate this might be other sort of subtle things like here. මේ බලන්න මේ මොකද්ද මෙතන තියෙන්නේ? ඔය හතරක් පහක් මං කිව්වනේ ඒවා හරි අමාරුයි වෙන් කරගන්න. But මේ වගේ දැක් තිබ්බොත් ලේසි. මොකද්ද මෙතන අපිට පේන්නේ? What can you see here? Cardiomegaly. So that is an indirect clue saying that මේ සුදු patches everywhere are heart failure. Pulmonary. Sorry, සුදු patches everywhere are due to pulmonary. Now ඔතනම ලියා ගන්න ළමයි in pulmonary edema there are some other features. මොනවද? මේ X-ray එක නම් ඒවා පේන්නේ නැහැ මම ඒවා වෙන දවසක පෙන්නන්න. What are the other features of heart failure? Of course it causes patchy sudu everywhere. But if you look carefully there are 2 other important features. One is upper lobe diversion where the blood vessels leading up to the upper lobes are more prominently marked. Upper lobe diversion. Blood vessels leading up to the upper lobes are more prominently marked. Upper lobe diversion. And also you might see these very small horizontal lines in the fissures. Those are called curly B lines. Curly B. Curly B lines. Right, so there are some questions. Sorry, I didn't see them. So Vinu is asking, so snowstorm appearance, Vinu, yes, you can call these sort of things snowstorm appearance. It is a non-specific term. Reticular nodule, I will show Purna, that is slightly different. I will show you. Bronchiolitis, you can get a similar picture, Harish, you're right. Okay, so that's right. Yeah. So remember 5 differential diagnoses of a patchy sudu thing everywhere. And අපි මුලින්ම කතා කරේ මේ වගේ localized ඒවානේ ළමයි නේ එක පැත්තක හරි ඔහම තියෙනවා. Now we are moving on to patchy sudu everywhere. 5 differential diagnoses. Difficult to differentiate. Heart failure වගේ features තියෙනවා. ඒක වෙන් කරගත හැකියි. එතන ඉතුරු ඒවා history එකෙන් තමයි හඳුනා ගන්න ඕනේ. The rest you can use the history to differentiate the story. Hari. Next component. So we have seen now patchy sudu everywhere. We have seen more localized things. Now we move on to nodules. So the next part of this discussion is on nodules. Gedi, nodules. Here you can see in this section multiple fine nodules everywhere. Podi tit wage. Fine nodules. Nodules bolo hammer tanama තියෙනවා. So these are called miliary nodules. Miliary nodules. Or miliary mottling කියලා කියනවා. Mottling කියලා ලියන්නේ මෙහෙමයි. Oh sorry, හැමෝටම යවන්න. So nodules. Mottling. So mottling, miliary mottling කියලා කියනවා. Miliary mottling. This you see in tuberculosis and also sometimes in cancers, right? එකට කියන්නේ miliary carcinomatosis කියලා. Some cancers can cause this appearance and that's called miliary carcinomatosis, right? So that is small nodules all over the place, all over the countryside. Okay, this is again a similar thing. Now here you see larger getting. Okay? That's a solitary nodule in a lung. Solitary nodule in the lung could be due to an adenoma, right? Adenoma of the lung, or a carcinoma of the lung. Right. On the X-ray on your right hand side, you see many of these nodules. Multiple nodules. So this is called a cannonball deposit metastasis. So single nodule, multiple nodules. Single nodule, multiple nodules. Hi. Okay, please, if you have any questions, please ask. Here you can see now another X-ray here, a nodule. So nodule එකක් වගේ තියෙනවා, but there is a fluid level. Right? It's not strictly a nodule, but there is a sort of a, you can call it a cavity actually with a fluid level. Now, මුලින් අපි solid එකක් නේ දැක්කේ. දැන් මෙතන there is a fluid level thing. This is a, what is this? This is a lung abscess. Then බලමු මේ ටිකයි. So now many small nodules, miliary, whatever, right? Then single nodule, multiple nodules, and sort of a cavity with a fluid level. All very similar looking things that you need to differentiate. This is a lung abscess. And if you look carefully, you can see this line also. Why? Because the patient is getting long course of antibiotics. Central line antibiotic. Because lung abscess, you need to treat it for long, sometimes 4 weeks, 6 weeks of antibiotics. Right, this is not very important. So those are the sort of, oh, sorry, I have to show you this. Right, reticular nodule එකේ හොඳ picture එකක්. මෙන්න මේක බලන්නකෝ. එච්චරම හොඳ නැහැ. But නෑ. මම වෙනම පින්තූරයක් පෙන්නන reticular nodule එකේ. So reticular nodule is a variation of this multiple small nodules. දැන් මෙතන ඔයගොල්ලෝ දකින්නවානේ multiple small nodules තියෙනවා මේ දෙකේම. So reticular nodule එකේ you will get nodules and sort of lines also. ඉරි වගේ තියෙනවා. මම ඒකේ පින්තූරයක් ඊගාව දවසේ එක පෙන්නන්න. Reticular nodule. Right. Harish is asking, in bronchiectasis, what can you see? So this X-ray is actually a picture of bronchiectasis. In bronchiectasis, you see these large sort of cystic dilated air passages. But it's very difficult to spot. And the other thing again, very difficult to spot is this. These are called tram-line shadows. All these thickened, dilated bronchi. Okay, fine. Right. So these are all these white lesions. Pleural effusion, hydropneumothorax, consolidation, collapse. So I give you three differential diagnoses of this appearance, right? Then patchy sudu everywhere, I'll give you 5 differential diagnoses, right? Then nodules, small nodules, reticular nodules, in some cases, large nodules, multiple large nodules, and lung abscesses. And I've also shown you a picture of bronchiectasis. Then black lesions are very easy because this is quite obvious. Air trapping and lung collapse, you can see that very nicely. Pneumothorax. So black lesion, the only thing you need to know is a pneumothorax. If there is black on both sides, this is not a very good example of it. Most likely diagnosis is emphysema. Right. And you can see this X-ray, you can see, oh, me ribs so pain on me. And that means that there is hyperinflation. Okay, right. This is not very important. Right. Okay. Now let's focus on the heart and the hilum. Heart and the hilum. මේ H එකට තව එකක් ලියා ගන්න. Heart and hilum. cardiac නේ H එකක් නේ. හරි බං. මේ D වලට පස්සේ H එකක් ලියා ගන්නකො එහෙනම් hilum. මේ this is just hilar lymphadenopathy. මේ ආසාවට බලා ගන්න එක මෙච්චර common නෑ. Occurs in lymphoma and sarcoidosis. Lymphoma and sarcoidosis. Make it don't worry about that. Right. Now, when it comes to heart shadows, cardiac shadows, cardiomegaly ඔගොල්ලෝ දැකලා තියෙනවනේ. ඒක මේ තියෙන්නේ. Cardiomegaly. Remember, the other cause of a very large heart is a pericardial effusion. Right? Very large heart could be due to a pericardial effusion. And when you come to professors, I will show pericardial effusions to you also. The other important cardiac thing you need to know is this. A left straight heart border. Samani heart border kalamai මෙහෙමනේ තියෙන්නේ ලස්සනට නේද? Here it is left border is straight. This occurs when there is hypertrophy of the left atrium. Hypertrophy of the left atrium. And that occurs in mitral stenosis. So, අපි ළඟ ඕන තරම් X-ray තියෙනවා mitral stenosis patient ළඟ. මෙන්න මේ heart board එක මෙහෙම දිගැරිච්ච. That is so. In the cardiac shadow itself, you will see these two things: cardiomegaly coming on frequently when you see patients, and also this straightening of the left heart border in mitral stenosis. Right. Right. Yeah, I think that's enough. Additional level. I will teach this later, but just for basics today, I think that is more than adequate. Diaphragm ගැන කතා කරන්නේ අන්තිමට මේ බානේ මෙතන මොකක්ද තියෙන්නේ? This is more of a surgical thing actually. Air under the diaphragm. So ABCD ටික කරන්න ලස්සනට hilum එකත් උන්න H එකක් දාගන්න. In the diaphragm, air under the diaphragm. හරි. Right. So that is all for X-rays. Right. Questions? Pneumatocoel ගැන වැඩි කලබල වෙන්න එපා. Don't worry about that. Harish. PAP ඉතින් ගහලා තියෙනවනේ. මේකේ ෆිල්ම් එකේ ගහලා තියෙනවා. කසු. Yumi or ප්‍රශ්නයක් අහන්න ඕනද?
Unnecessary.
බලන්න දැන් පැහැදිලිද කියලා? So chest X-ray ABCD H එකක් දාගන්න. Airway lung fields, bones and blood vessels, heart border, cardiac, diaphragm and hilum. ඔය ටික තමයි තියෙන්නේ. In the lung fields, you have white lesions and black lesions. White lesions, pleural effusions, hydropneumothorax, consolidation, collapse, pneumonectomy arammanam ඔය ටික. Right? Wedge-shaped infarctions. Patchy white shadows could be due to bronchopneumonia or some sort of thing like COVID wage, pulmonary hemorrhage, right? Then what else? Pulmonary hemorrhage, ARDS, pulmonary edema and pulmonary, right. Then small nodules, reticular nodules, large nodules, multiple large nodules, abscesses, bronchiectasis, and then we went on to the black lesions. Heart border ke hilum hilar lymphadenopathy, heart border ke cardiomegaly and straight left heart border. These are the important ones. Right. Stuff about penetration and we'll talk about when we do the X-ray class in the OSCE in your appointment. Don't worry about that. I will teach you. Can effusions occur in the upper lung fields? Yes, Sanjay. When it's encysted. Encysted කියන්නේ කාලයක් තිස්සේ pleural effusion එකක් තියෙනකොට ඒක වඩේට බිත්තියක් වගේ බැම්මක් වගේ බැඳිලා then it causes a something called in-sister diffusion. But those are difficult. Those are postgraduate things. Don't worry about it.
සර් එපිකල් ෆයිබ්‍රෝසිස් කොහොමද පේන්නේ?
මම ඒක පෙන්නුවේ නෑ නේද? Right. I will show you on a different day. I don't have an X-ray now to show you. But it essentially looks quite similar to consolidation, but with a lot of volume loss. Sorry, I forgot to put that in here.
සර් ඒකෙදි horizontal fissure එක displace වෙනවද?
Trainable. Oh, yeah.
එතකොට ඒක collapse එකෙන් වෙන් කරලා
වෙන් කරගන්න විදිහක් තියෙනවා මේ ඒකට appearance එක වෙනස් ගොඩක්. ඒක. Isuri is asking, yes, pneumonia can occur sometimes නිකන් රවුමට වගේ එන්න පුළුවන්. So yes, large salt radio DD එකක් විදිහට pneumonia වෙන්නත් පුළුවන්, but it's not very common. You can get a amutu shape of a pneumonia there. Yeah.
සර් solitary nodule එකට DD එකක් විදිහට adenoma තියෙනවනේ. ඒතර cannon ball එකට adenoma ලියන්න බෑනේ. ඒක හැමතිස්සෙම
Cannonball always is malignant. Yeah.
සර් ඒ වගේ වෙයි x-ray abnormality කියන්නේ කිව්වහම අපිට අර කොයි කියන්නේ cannon ball appearance කියලා ලියත් හැයිද නැත්නම් අර විස්තර කරලා ලියන්න
ඒක ප්‍රශ්නයක් නෑ.
coin lesions කියලා කියනවා සර්.
coin lesions කියලා කියනවා. ඔව් එක එක විදිහට මිනිස්සු පාවිච්චි කරනවා. ඉතින් ඒක ඔක්කොම ඉතින් අවුලක් නෑ. හරි. Sarangani, then shall we call it a day for today? Yeah, there are some other X-rays also, but we will sort of do it later. I think the chest X-rays are the most important ones. I think that's enough for today.
Do you want to plan another session?
No. I will then do the rest with the prof appointment. These are the big things, no? Especially ECG is the one that I want to do, and X-rays. So we have done that. So we can just continue as we are doing in the prof appointment teaching.
Okay.
Hari? Yeah. I will also start this MCQ, SCQ class later for your batch. 2013 night but it's too early to start it now for the moment. So about 6 months to your exam, we will start that also. Right? Yeah. Okay. Every week we do MCQs and SCQs. I will do later. Hari? Okay. I will see you again soon.
Okay, sir. Thank you, sir.
Right.